So this is an open session. Please admit everyone who is in the gallery because I will not be able to see the screen of team. Right. This is the first case. This is 70-year-old lady who has a background history of progressive multiple sclerosis, and she presented to us with intracranial hemorrhage, and she has pancytopenia. This is power 10. Now I will go to power 50. For those who have joined again, uh, the scenario is that this is 70-year-old lady with a background history of multiple sclerosis presented to us with intracranial hemorrhage, blood, full blood count shows pancytopenia. And this is the blood film. Because of the pancytopenia, cells are quite few in it, but those which are available and Evelyn, are you there?
Sorry, did you call my name?
Yes.
Oh, okay, sorry. Yes, I'm here, Dr. Amir.
You're going for the exam, so you need to report this blood film. Do you have any thoughts about this blood film?
So this blood film, the striking feature would be the presence of these very large atypical mononuclear cells. So they display an irregular nucleus, some of it shows bilobed and some appears folded. The chromatin is open, some with prominent nucleolus. They have a abundance of this eosinophilic granules, sometimes obscuring the nucleus. I'm unable to appreciate any cells with our rod so far. So the red cells otherwise, yeah,
This is power 100.
the
Okay.
red cells otherwise are unremarkable with just mild anisopoikilocytosis. Platelets are reduced. Taken together, these findings would be highly suspicious of an acute promyelocytic leukemia. And I would suggest referral to hematology.
There is also an RBC as well.
Yes.
Do not say refer to hematology. This is hematological emergency. You should say this is acute. The impression is APML, which would need confirmation on PML aurora stain. This
Okay.
is an emergency. I need to see this patient by myself and will inform my consultant to start the treatment as soon as possible in this patient.
Okay, noted. Thank you.
So I think I have shared you the hematological emergencies file with you guys. Um, when there is emergency, say it. This is hematological emergency or medical emergency, which need urgent hematology input. Refer to hematology means they will refer it after 6 hours, after 7 hours, when they become free. So on emergency situation, you need to say it, vomit it to the examiner, and act urgently on it. Similarly, if
Dr. Amit, your voice is muted.
so similarly, if this is a Waldenstrom patient, for example, uh, and his paraprotein are 100 and he is confused with extensive bruising, you cannot say refer to hematology. You have to say that this is hematological emergency. I need to see patient by myself and inform my consultant. Talk to apheresis unit to arrange plasma exchange urgently. If it was a CLL, mantle cell, or follicular lymphoma, then I can say refer to hematology. But in TTP and hyperviscosity conditions, you have to act quickly. So I think in this film there were only two bilobed cells and few hypergranular cells. Okay. So it is easy to pick that this is APML, but your response will make a difference in the exam to pass you in the short question or fail you in a short question. I think there are no other bilobed cells to show you. Um, this is the another one. I will make it at 100 power. Let me find out that document. We'll share that document again today, the hematological emergencies. You know. What treatment will you provide to this patient?
The immediate treatment I would provide will be all transretinoic acid for this patient and send
If,
off.
if the next part of the question is discuss the immediate management of this patient, how would you answer?
Admit the patient to hematology, look for any signs and symptoms of bleeding, send off the coagulation screen looking for DIC, and also peripheral blood for FISH for translocation 1517 and also reverse transcriptase PCR, and then start ultra without even waiting for the results of this genetic test. And if the patient has features of DIC to support accordingly to keep the INR less than 1.5, platelets more than 30, and fibrinogen more than 100 milligrams per deciliter.
Okay. So who is the another candidate of FRC? Danish, you are the candidate for the exam as well. You have heard the Evelyn answer. Please correct the answer.
Sorry, so I think in a first instance, I would, as I say, you mentioned that see the patient, discuss with the consultant, and in the management option, I'll explain the diagnosis to the patient. I will do send all the baseline investigations, including coagulation, UNEs, LFTs, virology, and then obviously urgent fish and for PML RARA and PML staining as well. Then as Evelyn mentioned, supportive treatment depends on patient bloods. So it will include fibrinogen replacement, platelet transfusions, and most importantly, the definite treatment at this stage will be ETRA. Um, um, I think that's probably the initial management, and then further management will depends on confirmation of diagnosis, risk stratification, and patient baseline status. And we also need to do further investigations like echo, ECGs, and things like that.
Okay, echo and ECG will come later.
Yes.
But this patient has APML and she has intracranial hemorrhage.
Oh, I didn't maybe
Okay.
didn't heard about the intracranial
Oh,
hemorrhage.
sorry.
Sorry.
Yeah, I missed that too.
So
Sorry.
I think obviously for I don't know if it was diagnosed on the CT scan, she will need a urgent discussion with the neurosurgeons. We need to keep the platelet target nearly over 100 with the platelet transfusion. Again, we need to nearly normalize the coagulation studies. And so further will depend on the neurosurgeons whether they want to manage it conservatively or it will be too high risk, obviously, for a patient to go for the surgery, but it will be the neurosurgeon's call.
Right. So please read your question twice in the short case because you have only 9 minutes and you have no choice for any mistake. Okay. Intracranial hemorrhage. Uh, discuss the targets. Platelet above 100. Hemoglobin about 70. FF. The fibrinogen about 2. As per our trust protocol, some hospital says about 1.5, right, as per my trust protocol. Um, and neurosurgical discussion. Discuss with the patient if she has mental capacity. If no, because she has intracranial hemorrhage. If no, then the next option. And then, yes, the APML related treatment urgently. ATRA, you can include you can include the arsenic or you can include the idarubicin. It doesn't matter now whichever you want, but that would need regular electrolyte check. Does cytoreduction have a role to play? If the white cell count is very high, then you can give cytoreduction. If the white cell count is less than 30, we usually do not give any cytoreduction. It depends on hospital protocols as well. Right. This is the second patient. This is a 54-year-old patient who presented to emergency department because of the gum bleeding. This is power 10. Now I will go to power 50, make it more clear. Our hemoglobin is 106, white cell count is 25, and platelet count is 130. Right. Is there any volunteer for this one? Sarah Nasser. You're there?
Yeah, I can. Yeah, I'm here.
Yeah. Mm.
So I can see there is a large to medium blast with open, with open chromatin. There is prominent nuclei, and I can see also the cytoplasm and the NC ratio is reduced, and there is also some cytoplasmic I'm not sure about that. And there is the red cell shows there is uh, mild and eosinophilicytosis, like apparent thrombocytopenia. I can see also the neutrophil have reduced as well.
Mm-hmm.
So my probable diagnosis for this case would be acute leukemia with the presentation of bleeding, nasal bleeding.
Okay. So tell me your report. You are in the exam and they have asked you report this blood film.
Okay, so the main thing that I have comment on there is the blood, which is large to medium to large, with some of them with reduced NC ratio. And also I see that some of them have nucleus, some of them, but not all of them. And there is nucleoli with open chromatin. And comment on the red cell. I can see that there is red cell anisocytosis. Um, there is no
Mm-hmm.
thrombocytopenia. I didn't see any, yeah, thrombocytopenia. There is all neutropenia. There is neutropenia as well.
So you have to comment everything you see in the blood film, even if it is red
Yeah.
cell fragment,
Mm,
spherocyte, or anisocytosis. You have to mention these things in all cell lines, even if it is a whole jolly body in the red cell. As the prominent feature here are the blast.
there is,
You have to
yeah,
you have to mention them first, okay?
yes.
Which you have
Mm.
commented on. Then you have to
There
mention
is
the
the red
rectal
cells,
finding,
and there is
and
the
then
polychromes. Yeah, yeah,
the blood film findings, and sorry, the platelet findings, then the impression, and then your suggestion as well.
yeah. So yeah,
Your impression is acute leukemia.
leukemia I need to send for yes, and I'm sending for immunophenotyping for immunophenotypic blood and for cytogenetic and molecular analysis.
Yes. So always say impression is acute leukemia, and you will confirm the lineage on flow cytometry,
Yes,
because we don't know. Sometimes they appear as biphenotypic or mixed lineage. Yes, it is very clear that this one has granules, but you never know. We have seen many cases in practice where we think this is AML, and it turns
yes,
out to
yes,
be mixed one or ALL. Yeah.
yes, yeah, yeah. Thank
So
you.
comment on the cell line first, which is affected. Here you have seen a lot of blast. So comment on the blast first. Then you can comment on red cell lineage, that there is an apocytosis or there are a few
Yes,
fragments as well. Then you can comment on the platelets. There is thrombocytopenia, no platelet plug scenes, and then your impression. This is acute leukemia. You need to confirm. This need to be confirmed on the by flow cytometry. This patient would need hematological
microcytometry.
investigation in the form of bone marrow biopsy and
Definitely.
admission to hematology.
Okay, thank you.
And then if they ask you in the next part of the short question, what is the immediate management of this patient?
immediate management, of course, would be like admission of the patient. He come with the bleeding. He need like to be examined and check his full blood count, clotting and fibrinogen. And there is a bleeding, he needs a transfusion. I need to know the number of the plots by itself. So if it's like number is very high, so we need to do a cytoreduction for this patient and put in our mind also hydration. And when the confirmation of the diagnosis, we will need to risk stratify the patient, and accordingly, we can start immediately the chemotherapy, and if he's a candidate for transplant later.
Is the candidate for what?
Transplant. If it depends on the patient. Yeah, I didn't consider about the age of the patient. I don't know the performance status. A lot of things which is need to.
Patient age is 54, but do not talk about transplant in the immediate management.
Because it
Immediate,
depends. Start chemotherapy. Yes.
yes.
Immediate management. I saw that it is
In,
all
imme-
management.
yes.
So it means that then.
In immediate management, discuss about clinical assessment of the patient. If the white cell count is high, you can give cytoreduction. If the patient
Yeah.
is bleeding, you can set target for the patient. If this patient has gum bleeding, you can send a referral to Max team or dental team to assess the patient. Okay, and then your bone marrow biopsies,
Okay.
the rest of the organ function tests, and consultation with the patient. If
Fine.
we have seen your blood film, it shows
Yes,
likely
that is
acute
important.
leukemia. All these things come under acute management.
Mm.
Do not mention about transplant if they ask you about immediate management. Okay? They will give you a next question that this patient has a normal karyotype on cytogenetics. What are the treatment choices for this patient? The last two mark question in the short case is this patient has a normal karyotype on cytogenetics after bone marrow biopsy. What is your treatment
Mm.
choice for this patient? I'm asking you.
I will have to start for him chemotherapy in form of DA, and because he have no any site to risk cytogenetics, so I expected that he may get a remission with two induction chemotherapy.
What what is the treatment choice?
I think in a choice we have to mention Veneza as well because we don't know the fitness of the patient. And then, as someone mentioned about DA, if it's normal karyotype, then yeah.
Yes, for fit patient, for normal karyotype, you have DA, the
DA,
standard
DA.
yeah,
I have
standard
an
chemotherapy. But you always have to say that I have to see at the patient comorbidities, performance, and fitness. If she is not fit for DA, then I will consider less intensive chemotherapies, which are now many. Okay, then is we have um, there are many others as well. So the next patient is a 19-year-old patient who has presented to the hospital after a fit. Okay. And now he is confused as well. He's just 19-year-old, and the CT scan shows hemorrhage, intracranial hemorrhage. This is his blood film. I'll go to the thinnest part. Yeah. So his hemoglobin is 90. His white cell count is 600, and his platelet count is 80. He had a fit, then now he's confused, and CT scan shows hemorrhage. And this is the blood film. I will go to power 50. I think we will stick on this slide because all the slide is like this. Anyone, any volunteer to comment on the blood film? To report the blood.
Oh, can I have a go?
Yes, yes, please. Go on.
Yeah. So there is a leukocytosis with pretty much monomorphic red cell population with high NC ratio, visible nucleoli.
Okay, you have commented on the white cell lineage. What about
Yeah.
the other lineages?
There's anemia with red cell anisopoikilocytosis, no red cell fragment seen, thrombocytopenia as well, no platelet clumps. Also going back to the white cells, some of the nucleus, they look a bit having a notch and can't see. It might be some of the cells have some granulations, but not all of them into the cytoplasm.
Okay.
And just a few normal lymphocytes.
Normal what?
Lymphocytes like with just a few. There's one in the middle.
Okay. Right. So what is your impression?
So it's acute leukemia with leukostasis. Patient needs. So I will need to send an urgent flow for lineage confirmation. And further cytogenetics, patient needs urgent admission under hematology ITU or cytoreduction, leukapheresis.
Okay.
Other transfusions, red cells, platelets.
So the blood film
Platelets to
shows.
keep the platelets above 100 because you got the bleed.
So this is the report. In the report, you comment on the cell lineage, your impression, and your suggestion what to do next. You have commented on a cell line. You have mentioned your impression that this is acute leukemia, and your suggestion is to urgent blood flow for the flow cytometry, hematology team assessment, and patient admission under the ICU because the patient has intracranial hemorrhage.
Yeah.
Right. So now you have sent the flow for this patient, and the flow has turned back as CD19 positive, CD10 positive, CD20 positive, and TDT positive.
So the lineage markers is CD19, which indicates a B cells lymphoma. TDT is a marker for the ALL, either BALL or TALL.
Mm-hmm.
I think that's the case from today's essays.
The case from
looks
what?
like.
From
I
where?
think that's the case from today's essays from yesterday. Sorry.
I don't know.
And looking back to the blood film, I think there are some cytoplasmic blebbing, which is seen in ALL.
Mm-hmm. Blebins can be present in many cancers.
So flow cytometry is indicating BALL leukemia.
Okay. So this is BALL because TDT is positive and you have B cell markers as well. Now the next question is acute management of this patient.
So as we mentioned, patient needs to be admitted in ITU because of intracranial bleed. He needs urgent cytoreduction and chemotherapy. And also close monitoring for TLS. The initial management for ALL, BLL is the pre-phase steroids, but given this high white cell count, there's an increased risk of TLS. So yeah, you need good hydration, respiratory.
Right. So you have suggested this treatment, and then
no, I think because of the increased white cell count, probably you need leukapheresis first to reduce to remove the malignant cells.
Dr. Rekha said that she would like to answer this question as well. So let's see her answer, what she said. Rekha?
Yeah.
Yeah.
So
Acute
the comment.
management of this patient.
Okay. For the acute management, the patient need to be immediately admission in ICU with all ABCD assessment, and patient need to be look for the signs of other leukostasis, and for patient will go for leukapheresis because of high high blast count, and however the platelets will be maintained, and because of bleed, it should be more than 20, I think, for the leukapheresis. And soon started with the DEXA. If ALL is confirmed, then for DEXA with the TLS protection. And patient need to be counseled and explain about all the results and complications. And yeah, MDT is first. Neurosurgeon involved will be the first.
Naveen says that she would like to answer this question. Naveen? Can you hear us, Naveen? Naveen Vera.
Hello.
Yes.
Yes. Regarding the immediate management, I'll divide it into multiple aspects. One will be management of the bleeding and this thing. So I'll be keeping the platelets above one. I'll be assessing for the blood count, and first is the patient assessment. Then second will be management of the immediate symptoms. The patient is having bleeding. The patient will be admitted to the ITU, and we'll be taking a neurosurgeon opinion and keeping the platelets above 1 lakh in view of intracranial bleed. And third will be management of this primary management of the patient, preliminary management of the patient. The patient is having hyperleukocytosis, and we'll look for symptoms of hyperviscosity, and also the patient is at high risk of tumor lysis syndrome. So we will be starting on tumor lysis prophylaxis with hydration and allopurinol if allopurinol. And the definitive treatment could be, in this case, to be starting him on prephase steroids, or for cytoreduction, we can go for leukapheresis if facilities are present. And concurrently, we'll be counseling the patient regarding the new diagnosis, and we'll break the bad news, and we'll also provide them with the treatment options. And concurrently, we'll also be sending the sample for further risk stratification of the disease and to determine the main therapy or definitive therapy.
Okay. So there are multiple aspects in this patient. The patient has very high white cell count. He has blood. He had a fit. He is now confused. A CT scan shows intracranial hemorrhage. The priority is to reduce his white cell count after admitting him to the ICU. Okay. So you will check the coagulation screen. Make sure the fibrinogen is above 1.5. If it is less than 1.5, you have to give fibrinogen to the patient, because if you do leukapheresis with low fibrinogen, the bleed will expand. So make sure you mention coagulation screen with cross fibrinogen. This is important. You replace the fibrinogen first, and then you go for leukapheresis. This patient will need platelet transfusion as well, because the platelet count was 80. And then you do the leukapheresis, you start the cytoreduction with chemotherapy in the form of dexamethasone, or in the form of chemotherapy, cytarabine, if you want to give. We usually avoid chemotherapies because this patient will go for any trial in the future to uh, to avoid that problem in the future. So cytoreduction for the high white cell count is first, after transfusing him with fibrinogen concentrate if it is low, and platelet transfusion. Then surgery consultation for possible intervention. He had a fit. You have to consult neurology as well for a review and their opinion regarding epileptics to prevent further anti-epileptics in this patient. Discussion with the patient, but he is confused, so you have to inform the next of kin. Then the next important thing is the TLS management in this case. Do not forget leukapheresis, do not forget TLS, do not forget ICU admission, um, and the neurology and neurosurgery involved. These were the few important things in the acute management. If you miss any of them, then the answer will be considered as unsafe answer. So do check fibrinogen. Why we don't do um, leukapheresis in APML? Because APML patients come with DIC, and then fibrinogen is very, very low. So if we try to do leukapheresis in APML patients with intracerebral hemorrhages due to leukocytosis, their bleed expands. That's why checking fibrinogen is important in bleeding patients.
I can ask in this case, you're waiting
Mhm.
for flow to confirm the lineage. I mean, do you have time? If it's an APML, you usually think of.
No, this is not.
if
This is not an APML case.
Yeah.
I have told you the flow already, that this patient
Okay.
has
Yeah.
B cell markers with TDT positivity.
Yeah.
If TDT is positive, means this is.
Yeah, but I was asking in general, on your initial investigation, you don't have the flow yet, and you're in doubts about the cell lineage, or if it's an APML or not.
Morphologically,
Yeah.
these cells were not like APML.
Okay.
These were all lymphoblasts.
Mm.
they were quite different from the cells of the cells of the APML that we saw in the case number 2.
Oh, I was not here when it was case number 2. Sorry.
Okay. So when we did the case number 2, the cells were very clear. They were few. They were myeloid looking. They were having a lot of granules, and
Okay.
we saw two cells which were clearly bilobed.
Okay.
Right. This is again a 19-year-old girl who has presented to emergency department because of fever. And this is his blood film power 10. Hemoglobin is normal, platelet count is normal, white cell count is 14, and this is the blood film power 10, and the biomedical scientist has flagged it up as leukemia. Now the blood film is with you, and let's see what is on power 10, power 50.
Sorry, Amir, what was the history? 10-year
This is
old?
19-year-old girl, okay, with hemoglobin of 140, platelet count of 356, white cell count of 14. She has come to emergency department because of recurrent fever, high grade fever.
Recurrent what? Sorry.
Fever,
Oh,
temperature.
okay. Yeah.
Okay, and she has a background of splenectomy due to road traffic accident.
Mm.
So this is her power 50 pin. I have shown you the power 10. The biomedical scientist has flagged it up as leukemia. Is there any volunteer? Right.
Can I
Yes,
can
yes,
I have
go
a go?
on.
Yeah.
Yes, yes.
So I think initially when you presented the film, I think I saw some spherocytes. So yeah, so the red cell lineage. Oh, okay. There is microcytosis with some red cell with holy jolly body, in keeping with splenectomy. Some bite cells, again due to splenectomy.
So when we were telling you the full blood count, the full blood
Yeah.
count said hemoglobin is normal,
Normal.
platelet is normal, white cell count is 14. So the problem is with the white cell lineage. To comment on the
Okay.
white cell lineage first, then go
Yeah.
to red cell and then platelet.
Okay.
So affected lineage should be
First.
commented on first, yeah, in the report.
Okay. Okay. So the nucleus from the white cell count looks, the chromatin is condensed. There are some
Go on.
yeah, so on this film, I think it's a neutrophil. I don't. There is a smear cell.
Okay. So the blood film shows leukocytosis.
Yep.
There,
yeah.
there are multiple white cells or lymphocytes with
scalloping or the cytoplasm.
with a red cell scalloping.
But the nucleus chromatin is not open. With condensed chromatin, looking more like reactive lymphocytes, lymphocytosis.
Okay.
And I saw some normal segmented neutrophils with granulations in the cytoplasm. And the red cell lineage with village body cells in keeping with non-splenectomy.
What is your impression?
So it looks like a reactive picture with atypical lymphocytes, probably a viral infection. I will request for a EBV virology monospot test. But yeah, again, the spherocytes on the blood film, and I think I saw a nucleated red cell initially, which is in keeping with hemolysis, but the hemoglobin was normal, so. But
I didn't notice the NRBC.
I'm sorry?
I didn't notice the NRBC.
It was initially, I think it was somewhere on the left, but it was just when moving the film, so I'm not sure if it was the blurred or
Right.
just the beginning,
So,
but yeah.
What investigation would you like to do for this patient?
So I would like to do a hemolysis screen, to run a flow cytometry. Sorry, not the flow, to run a viral serology, checking for EBV.
The water serology will include your EBV, monospot
Yeah.
test, and also
Yeah.
hepatitis B, C, and HIV as well.
Mm.
We do all this virology in the young patient if we are suspecting infection mononucleosis. And then the treatment.
So the treatment, if EBV is confirmed, would be monitoring of the LFTs, and avoid contact sports. Advise the patient that.
Why to avoid contact sport?
I think EBV can. Yeah, she's got splenectomy. Yeah.
Do not forget to comment on these cells in your blood film. Okay, this will carry a mark as well.
Yeah, so that is a that the band neutrophil.
These are bands, yes. Anyone disagree with her report?
Oh, I think it's a fairly reactive film. There are mature neutrophils with some bent forms. The red cells, as she mentioned, there are some whole Jol bodies. I can't see any NRBCs as well. I may be able to see one stomatocyte somewhere. There is a platelet anisocytosis with some large platelet, again keeping in with the post-splenectomy changes. The white cells, as I say, mostly mature. There are some secondary granules in cytoplasm, but I'm not sure whether it's just a reflection from the camera or there are actually. But mostly it's a reactive film. Yeah, it's consistent with the viral infection, likely.
Right. So your junior, who is a ST3 now, came to you. What is a reactive lymphocyte? How to differentiate it from clonal lymphocyte? Oh, what advice you will give to him or her?
I think if we suspect a clonal population, usually the chromatin is more open, it's not condensed. And usually the clonal cells are more. The NC ratio is very high in the lymphoblasts, with almost invisible cytoplasm. And here in the reactive, we can see clearly the cytoplasm scalloping the cell, and also visible nucleoli sometimes in the nucleus in the clonal cells.
So
and
when
also,
we,
you looking around, if it's a possible lymphoma, you should see abnormalities in the other cell lineages, like neutropenia, thrombocytopenia.
yes,
I mean, in this
abnormalities,
case, the other ones are normal, platelets normal.
yes, abnormalities and other cell lineages, and in lymphomas, you see same sizes of the lymphocytes.
Yeah.
Okay. But in rectal lymphocytes, all the cells are of different shape. They are distorted. Some are large, some are small, um, and they have no unified shape. And the cytoplasm is more bluish, more basophilic. Still, you will be able to see nuclei in them, but it does not mean that they are blasts. So they are of different sizes. Okay? There is no unified shape in it. Some are very large, some are very small, distorted, uh, basophilic cytoplasm. Majority of them has basophilic cytoplasm. There are few cells whose cytoplasm is less basophilic, other have more basophilic cytoplasm. And the other lineages, they are normal. And for the exam, your patient will be young. And the patient will be teenage or patient will be in 20s.
Yeah, kissing disease. So
Yeah. Or the fever, patient will come with fever or sore throat or cervical lymphadenopathy. To distract you, to lean you towards lymphoma, they will say patient has cervical lymphadenopathy. It doesn't mean um, lymphoma. Okay, we all get cervical lymphadenopathy when we have sore throat. This is infection mononucleosis. Do not write kissing disease in the exam. Write infectious mononucleosis. So we have the last case now. This is a 60-year-old patient who has a new diagnosis of pancreatic cancer. And he is febrile with high CRP. She has developed anemia. The hemoglobin is 80 or 10 first. So hemoglobin is 80, platelet count is 350, and white cell count is 14. This is power 10. I will go to power 50 now.
so what the platelet count?
356.
Okay, thank you.
All right. So what do you think is going on here?
Is that one, that cell?
Hmm. Mean NRBC? No, there is no NRBC here.
No, before it was is it abnormal neutrophil or
This field,
no, not this one.
You mean this one?
No, I thought it was a dysplastic neutrophil, but I don't know.
Yeah.
But there are some red cell fragments.
So report it.
Oh, oh yeah, this one in the middle, neutrophil.
How would you report the blood film?
So there is anemia with red cell anisopolyscytosis and red cell fragments present on a 20 power field. I would say there are 4 or 5. Platelet count is normal. The neutrophils, some of them are normal segmented. I think some of them they're dysplastic. Couldn't see any lymphocytes. There are some teardrop poikilocytes, a few. One now visible in the middle.
Mm-hmm.
Normal neutrophil with the round nucleus. Sorry.
Right.
What this?
Go on with your report.
Sorry.
Your report. So you commented on red cells. What about the white cell platelets? Your likely impression and your suggestion to the team. Danish, how would you report it?
So I would say there is a red cell anisopoicocytosis with presence of fragments in high power field. There are NRBCs and occasional teardrop cells. The neutrophil, some are more reactive, hypergranulated, and there are a few left shifted as well. The platelet counts appear normal with platelet anisocytosis with some large platelets. Keeping in a history, overall, the film suggestive of TMA secondary to pancreatic malignancy with preserved, I would say, platelet count. Advice would be to continue observation, check for treatment of the underlying cause is the most important management.
This patient has a very high CRP as well, as mentioned in the question.
Yes, there are some toxic looking neutrophils and some left shifted as well.
Hmm, yes. So, what would be the treatment of this patient?
So the treatment would be from hematology perspective. Well, it will be treatment of underlying cause, infections with antibiotics, and um there is anemia, so they can look. Well, in exam setting, I think I would suggest to do hematinics and observation. Yeah.
Whenever there is hemolysis, you always say, please give this patient folic acid.
Okay. Yeah.
Whenever there is hemolysis, because
Yeah.
yes, this is a MAHA secondary to infection and pancreatic malignancy with preserved platelet count. Platelet count is on higher side because of the ongoing infection. But if the hemolysis is there, yes, you have suggested hematinics, but you have to suggest folic acid as well.
Yeah, that's right.
So usually such blood films are quite common in our practice, but in exam they can give you, the BMS has noted multiple fragments and she's worried for TTP in this patient. So always look at the scenario again. What is the platelet count and is there any underlying cause present or not? For example, this is the case that the 50-year-old patient with pancreatic malignancy presented to emergency department because of fatigue. Her hemoglobin is 80 and platelet count is 70, for example. White cell count is 13. Would your management be different in this case or still the same?
I think it will be same.
There is anemia, there is thrombocytopenia, there's a lot of fragments.
So we can do the DAT and haptoglobin and LDH just to ensure it's not autoimmune. Going on a line of TTP will be a bit tricky.
But the
I think you
possibility
can't.
is high of TTB in this situation. So I need to send urgently for Adam 13. And I need to, I think, to confirm the diagnosis with TTP center. And if it is confirmed immediately, I need to start management of TTP. It's just to explain to the patient and prepare for central line and need to transfer the patient to TTP center within 4 hours. And at the same time, so all the basic investigation and prognostication should be done, troponins and also discuss with the lab for defrost the plasma. So he will be starting stem transfusion as soon as possible when he will be there in the TTP center. And if there is a delay in transport, I need to start plasma infusion in my center.
Okay, good. But Islam Abdullah is not agreeing with you. Islam?
Oh, I am driving whilst commenting that. Can you hear me well?
Yes.
Right, okay. Wasn't there at the beginning, but I understand that this patient's got a pancreatic malignancy with some evidence of thrombocytopenia and fragments, and he's got evidence of sepsis as well. So I'll be keen to review systematically his full blood counts, liver function test, and coagulation, especially fibrosis level. So basically, I'll be making sure that this patient is not in DIC, because patients with malignancies, they usually present with DIC from cytopenia. And it's very unlikely for a patient with a malignancy to have a TTP. It's not the top of the differential diagnosis, but I would leave it at the bottom of my differential diagnosis, but not the first. So patient needs to be supported by products and treat underlying cause, which is, I believe, could be peripheral obstruction coagulopathy and DIC. Make sure that the patient is not bleeding, and anyway, we need to optimize PTNA, PTT, and fibrosis level. Platelet count is 13. If the patient has got evidence of bleeding, we need to keep a higher platelet count based on the type of the bleeding of the patient. As I said, I didn't listen to the history very well, but I don't know where the patient is bleeding. So the platelet cutoff would depend on the bleeding sites, if any. And we need to treat the underlying infection and monitor the patient. Also, because there is some evidence of someone mentioned spherocytonucleate blood cells. If this is the case, we're looking at MAHA. I think it will be also good to consider hemolytic uremic syndrome if there is any low or deranged renal function test. That's all I think about this case.
So TTP is either primary or secondary. Primary is immune TTP, right? And congenital as well in the very young age. If you have a secondary cause present, which is the pancreatic cancer in this case, you do not do plasma exchange. You would discuss this with the TTP consultant, but when he or she knows about pancreatic cancer, they would say not for plasma exchange. Please treat conservatively, which means with blood transfusion support, check hemolytic screen, hematinic screen in this patient, and give folic acid thrombophylaxis to the patient. Do we do plasma exchange in secondary TTP cases?
Of course, no. If of course, no. My question, my answer is just if it is confirmed. But in this case, I understand that he has had a cancer, so it is mostly TMA, and even Adam's 13 level will be not low in his case as well. So I agree that will be the treatment should be like support of the patient, clotting profile and everything. But I mean that in case, I mean that if this confirmed. So yeah, agree.
Pancreatic cancer is one of the commonest cause of
Yes,
secondary
is
TTP.
the commonest cause and also the worst prognosis as well, worst prognosis cancer as well. So even the prognosis be 6 months maximum for
Okay.
expensive life.
And those who are working in transplant centers where they do allogenic stem cell transplant, they would have seen a lot of secondary TTP as well post transplant. We do not we do not do plasma exchanges in.
A straight underlying cause, yeah.
So yes, if you say that it will be discussed with TTP
Dr.
consultant.
Amir, is that the case for the secondary TTP?
Yes, in secondary TTP, we do not do
Uh,
plasma exchange. The
yeah,
advice is
but
always
there is not that much thrombocytopenia in that case.
We don't
no.
call it TTP.
Yeah, because
We
Yeah, isn't
it
it?
should be
You're talking
MAHA.
about TMA and MAHA.
Yeah.
no
We're
no
not, we're not calling that TTP.
we are not discussing this case. We have changed our scenario that, for example, this is the
Okay.
case
Okay. If
with,
the platelet
with
are
anemia,
decreased.
with
Okay.
anemia, thrombocytopenia, and a lot of fragments like this, and the patient has background pancreatic cancer. What would we do?
Okay. Okay. Thank you. Yeah, because I was thinking that in this case the thrombocytopenia is not that much marked for the TTP. So
No, not in this case. We have
okay.
changed our scenario to
Okay.
discuss secondary TTP.
Okay. Thank you.
Hmm. Any question?
Yeah, hello.
Yes, go on.
Yeah, I just want to confirm if we are sure that this is a secondary TTP and we know the underlying cause, do we still need to discuss with the TTP consultant?
If you are sure, then we do not discuss. Okay, but there is not such mention in the guideline that they should not be discussed with the TTP consultant. We flag them to them that we have a case who has low hemoglobin, low platelet count, but there is underlying suspected cause as well, which is pancreatic cancer. Should we do a plasma exchange or should we refer it to TTP center or not? They would say no because it is not clearly mentioned in the guidelines, and you are a junior as well. You always take an opinion of a senior. you will in the exam you will say, I know this is a secondary TTP. It does not need a plasma exchange, but I will learn it through the TTP consultant to make sure I'm not missing anything. So this is your safe answer for the exam.
Okay, thank you.
Right.